Hello and welcome to this special APNA webinar. The Australian Primary Healthcare Nurses Association, APNA, is the peak professional body for nurses working in primary healthcare. APNA champions the role of primary healthcare nurses to advance professional recognition, ensure workforce sustainability, nurture leadership in health and optimise the role of nurses in patient-centred care. APNA has loads of resources and online learning modules, including mental health around identification, communication and management, and teams, disorders and early intervention. Our topic for this evening is psychological distress in primary healthcare. To begin with, I would like to acknowledge the traditional custodians of the land and sea on whose lands we work and live. We wish to pay our respects to all traditional owners and elders past, present and future. My name's Jo Millard. I'm part of the nursing team in primary healthcare and nursing support team at APNA. And I'm also have a project officer role. Prior to this role, I worked as a clinician, a clinical team leader in a large rural practice in Victoria. This experience helped me to understand the daily challenges faced by nurses in providing mental health care for our patients. One of the key learnings from 2020, the year of the nurse and the midwife, what would Florence have made of our year, when working with nurses was, and for matter all healthcare providers, is the growing challenge of providing care for people presenting with or living with mental health conditions, particularly during COVID-19. Additional challenges may be faced related to limitations and guidelines around the MBS. Nurses may be confused about their role and what they can and can't do and how they can or can't contribute. And we know nurses are often at the front line for patients presenting with mental health care challenges, and it's often us explaining the scope of practice and financial concepts. It's important for us as nurses working in primary health care or general practice to build our confidence in how to assess patient needs, provide mental health first aid, understand applying the MBS, and we are ideally placed to advocate for patients and improve care. And that's what brings us here today. The aims of the session are to enable you to increase your knowledge, skills and confidence by improving understanding of how to create a safe environment to support your patients' engagement with health professionals for their mental health care, of your scope of practice, medical legal considerations and importance of effective documentation in relationship to mental health care, in assessing risk and providing crisis management support, of comorbidities and care planning considerations, in how to use evidence-based resources and practice software templates to support your care. Just a reminder, after you've watched the Redback housekeeping video, remember to check the top right of your screen. We have a resource via the chat that you will see on your screen, but apologise in advance if we're not able to answer all the questions in the time we have this evening. Now, we would like to engage with you, and to help us understand who is in the audience today, we'd like to start with two quick poll, or actually we've got several poll questions. So the first poll question, if we can get that to be brought up. And the first poll question is, what is your professional role? Is it APNA program participant, RN, mental health care provider, EN, practice manager, nurse practitioner, GP, PHN staff or other? And if you've put other, would you please load it into the chat box for us? Sorry, Jared, I just can't see the responses there. We might close off whenever you're ready. And I think we'll launch the second poll question. How skilled, knowledgeable and confident are you in providing mental health care to patients presenting at your practice? And your options are, for the second question for the poll, very confident, confident, somewhat confident, not confident, no training or experience, or it's not applicable because you're not providing clinical care. And we'll move to the next poll question as well. We'll open that up and keep going. What percentage of patients, on average, that you see each day, do you believe display psychological distress? So the options are, the patients are showing no signs of psychological distress, 1 to 10%, 10 to 25%, 25 to 40%, 50% or more are showing signs of psychological distress or not applicable, I'm not providing clinical care. And I think we'll keep going, Jared, please, with opening up the poll. So we'll move to question 4 so that we can collate some of the answers. So how would you rate your stress levels in the last month? Options are 0, absolutely no stress, and 10 is extremely stressed, the worst I've felt. This information's de-identified and confidential, so we're just trying to get a sense of what's been going on in your lives in the last month. And then, Jared, we've got one more poll question, but I'll just check in with how we're going. So it looks as though most people are RNs. People are mainly somewhat confident. There's quite a few people that are not confident at all. With the next question with how you're feeling at the moment, we might just hold on for that later and we might just launch the 5th poll question, please, Jared. How would you rate your stress level right here now, being with us here this evening, where 0 is you're not stressed at all and 10 is you're extremely stressed, the worst you've felt? We thank you for sharing with you. Thank you for sharing with us how you're feeling this evening. And Renee, our presenter this evening, will be coming back to what you've told us shortly with our learning. So we'd love to hear from you during this session, as I've mentioned. If you have a question, please feel free to ask. Just type it into the message box at the bottom right-hand corner of your screen, and we should have time to get through some questions. And just a reminder that this session is being recorded, and you'll receive a link to the recording following the session when we've had time to collate that. We also ask that you take a few minutes to complete the survey at the end of the webinar because your feedback is important to us. Now let's get started. I'm delighted to introduce Renee Hayden. Renee is CEO of Anther Healthcare Limited, a leading not-for-profit delivering primary health, mental health services in New South Wales and Victoria. And I'm going to hand over to Renee to tell you more about herself because she's the expert on herself. Thanks, Renee.
Thanks, Jo. Hi, everybody, and welcome to our very different version of delivering this. Everyone's from home, and I'm hoping that we don't have disturbing dogs and children running around in the background. So I just want to acknowledge the time for you to be here tonight, given that we're pretty well all over Zoom and over webinars, and I think it really shows just how much psychological distress is impacting on general practice just with the enrolments we've had tonight. So I just want to acknowledge that for you all. So I am Renee Hayden. I am the CEO of APMA Healthcare, Australian Primary Mental Health Alliance, short for APMA. And I'm also a director and trainer for Alea Partners. And my background is, I'll switch to a slide because we've already done the objectives, but just to let you know that I am a mental health nurse and family therapist. I have been working in and around primary care and mental health for roughly around 25 years now. I started in divisions of general practice 2 years after they were born and have continued to work within the primary mental health space throughout that time and seen it grow into quite a big beast that it is now. I work with PHNs as a consultant, but we also deliver services under our healthcare. I was a practice manager and a practice nurse, so I understand a lot of where you're coming from and what happens in the very busy practice. And I'm also often in my spare time very much advocating for nurse equality under EBS. So just to go back, as Joe has done, we've done a bit of taking at the front end just to see how you guys have been travelling in relation to, the last 3 to 6 months since COVID, the environment has hit us and apparently a new normal, but also to check in how you're doing now. So just let me, what we might do, are we happy to switch to the polls, Joe? Just have a quick check of that, what we found. Is that all right? Can I do that? So with the polls, if we have a look at this, and I'm just trying to think about I don't understand the score.
Hi, everybody. I'm really sorry about that. This is the new normal, apparently, that we're in, and internet always seems to fail you when you need it the most. So I apologise about that. So I just wanted to explain to you a little bit about primary mental health in Australia, specifically that is wrapped around general practice and primary care. Most of the services that really sit and wrap around general practice are funded through the Department of Health, which is federally funded. Those sorts of services include all various types of e-mental health technologies, which include telephone, internet, smartphone apps. They're free and accessible for most people to access, and I will show you some slides about what is available. The other stream is better access, which is Medicare funding, and that usually is instigated or has to be instigated by a mental health treatment plan, with the exceptions of the bushfires. Of course, people have been able to access that without a mental health treatment plan. Often, sometimes, and even with the COVID environment with telehealth, often the better access environment does attract a gap fee. So one of the things where it's really incumbent on us to ensure is that we understand if we're referring people through to better access or Medicare funded mental health, that we understand that there may be some out-of-pocket expenses. So, and I'll talk a little bit more about that when we talk about referral pathways. The other stream, which is now called the mental health step care stream, that has been available for approximately 5 years since the inception of primary health networks. And the mental health step care stream particularly has reformed and remodelled the mental health nurse incentive program and the old ATAPS program into 3 particular steps that allows, or acuity sort of steps that allows people to access care commensurate to need. So it's a little bit more refined to how the person's presenting, and it's for a defined population, and particularly focusing on more disadvantaged, low-income people. So a mental health step care model, I just want to focus a little bit about this so you understand the steps, or it's like a chronic disease acuity pyramid, but done in a fashioned step. So if you look to your left, you have the well population, and the well population, what the peak bodies that are focusing on that are usually your Beyond Blues, etc., that and Reach Out and all of those that are usually looking at trying to reduce stigma. At the moment, those services now are coming more into the low intensity area, but peak bodies are looking at trying to get people to reach out when they're feeling a bit wobbly. It's okay to not be okay. Support your friend, have a conversation. The 3 steps in the middle, low, medium and high, are funded by the primary health networks. Also, the medium step is Medicare funded. So you can start to see that Medicare really funds just one stream, whereas primary health networks fund all the way through to low intensity to severe and complex. So actually the 4 steps. So it allows you to see how they've refashioned what was typically a medium and a severe step into a more broader brush to allow people to receive the care that they need based on what's going on for them. And then you have over to the right the tertiary services. The tertiary services are those typically run by a local health network, local hospital network, or LHD, and they are the public mental health services. The public mental health services provide the inpatient units, community mental health teams, the acute response teams, the secure extended care services, etc. And each state has a little bit of a different explanation about what their services they provide, but they're funded by the state. All of those that are in the middle are funded by the feds. I hope that makes sense. So let's talk a little bit about the realities of mental health in general practice and what happens. Let's remember that patients rarely book the appropriate amount of time for their consultation. They'll often just ring up, say, I need to make an appointment's made, and then we'll come in with a list of things, whether they be chronic disease issues or whether it be a whole variety of social issues or whether it be for mental health. A lot of our patients don't understand that they need to book a long consultation for multiple issues. So what often happens is in a consultation with a GP, 5 or 10 minutes in, the person will start to reveal that they're struggling psychologically. And a GP has this very small window to then do all of those things that are listed in the dot points to be able to complete a thorough mental health treatment plan. And of course, they're often not done completely well. And I don't mean that nastily, it's just that the GP is rushing to try and get the main things done so they can get the person sorted. For us nurses, patients sometimes just turn up at the door, they need our help and they've got no appointment. We're trying to squeeze them in so we can address what's going on for them. The patients often break down during physical health assessments and wound dressings and chronic disease assessments, etc., because they feel comfortable in talking to us. Often they'll talk to us more freely than they will a GP because they don't want to bother the busy GP. We tend to be more available to be able to hold space and give time. And I suppose that you'll probably find that many of your patients will tell you what's going on for them emotionally. Nurses working with chronic disease management and comorbidities will often encounter psychological distress in their patients. The chronic disease very rarely goes without psychological issues. People get quite distressed by the complexity that's going on for them and their bodies. The realities of mental health in general practice. So what often happens, because people haven't booked in an appropriate amount of time for a consultation, the mental health treatment plan is often completed just to get someone to be referred. Because often people will come in and say, my psychologist says, if you give me a mental health treatment plan, I will be able to get some subsidised sessions, or I can get referred to a primary health network program. So GPs are almost like a retrospective referral. Or the GP is just trying to get it all done to do the referral. The mental health treatment plan is often seen as purely as a referral process. At times, the practice nurses are asked to do and prepare the plan by the GP. The mental health treatment plan is often squeezed into a very short consultation appointment. The treatment plans often have many, many gaps in them, and I'll give you some examples, and I'll show you some examples of ones that we've received recently. The medico-legal risks are quite real when it's rushed like that, and many GPs are really unsure how to implement the item to their advantage, the item numbers to their advantage. So what should happen is on the right. A mental health treatment plan is there to remunerate the GP for completing a thorough mental health assessment. It's there for them. It's a remuneration item number for their time spent with the patient. It just so happens to have a bonus outcome, and that is by billing that item number, it triggers and opens up the door for Medicare item numbers for mental health social workers, mental health OTs, psychologists, and general psychologists and clinical psychologists. Practice nurses are not permitted to prepare a mental health treatment plan. It is outside of your scope of practice. Unlike a chronic disease management plan and team care arrangement, you are able to prepare that on behalf of the GP, but you aren't allowed to do a mental health treatment plan, and I can't stress that enough, because I speak to practice nurses all the time, and many will say to me, the GP wants me to do it, and I just say, you can't do it. It's outside of your scope. And that's where the medico-legal risks start to come in for yourself. Mental health nurses can prepare. If you're a mental health nurse, you can prepare the mental health treatment plan, but you can't obviously sign it off. All aspects of the assessment and the plan must be completed, and there should not be any gaps. And I'll talk to you about gaps in templates and why that becomes an issue shortly. So some of the medico-legal considerations, and you'll see this when I show you very shortly some of the mental health treatment plans of why there are issues. We need to really understand as nurses what's in scope and what's out scope for us in the area of speciality that we're working in. Both GPs and nurses should be practicing defensive medicine always. It's one of the things the AMA really stresses. And that means whenever you shut that client's file, you need to feel confident and competent that what you've put in there is exactly at your scope of practice and what is relevant for that person at that time. Assessment tools and templated forms in the practice software are fantastic things, but if you're going to use them, you should never, ever leave a blank. And I'll explain shortly why. One of the things as nurses is we should be really clear about is that we can describe symptoms of life. We don't need to be, and we shouldn't be doing diagnoses, especially around mental health. Mental health nurses can, but not practice nurses. We need to be really clear and communicate what's going on for this person and what are the symptoms of their life and the issue that's going on for them right here, right now. Remember that consent must be indicated or signed, and often we will get referrals for counselling and things like that, where we can't actually move ahead without there being an indicated consent, because we're breaching privacy to do that. And we might ring a home number, and someone said, I haven't given you consent to ring this number, and you know, it can be quite difficult for the patient. We need to think about the duty of care for follow-up arrangements and make sure people are covered. And nurses should always provide a summary of the presentation and not give a diagnosis, which I spoke about. And I suppose the last thing to think about, in a court of law, when you shut that file, how would you defend yourself with what you've written and what you've actioned? And that's the most important thing to remember. And I had the same slide for GPs. It's really important to make sure that when you shut that file, and we all know that best practice and medical director and ZMed and Genie all have a time process on it, and it also tells you when the file's been opened and shut. So it's a tracking. It's really important to make sure you do what you need to do. One of the things I want to talk to you about, this has come out of, we have done this presentation before, and there were some questions around medication. So I just wanted to talk to you a little bit about understanding mental health medications. And I'm not going to talk about specific drugs, but I just want you to understand that with any medication administration, we need to ensure that you understand you have a practice policy and there's procedures, and that's guiding you and also your scope of practice. If you are administering psychiatric depots, please make sure that you understand the side effect profile, any contraindications, how to safely administer that medication, and whether you need to do some post-administration monitoring after you've done that. There are many antipsychotic medications that can provide extrapyramidal side effects, dystonias, dyskinesias, all those sorts of things, and we need to be monitoring that. The last thing we want to be doing is administering medication when someone's having severe side effects. So we need to check that stuff out. So in relation to psychiatric medications, there are two major types typical first-generation older antipsychotics. These medications have been used since the 1950s, and they have quite severe side effects. And then you've got your atypical second-generation newer antipsychotics, and these medications have been used since around the 1990s. Both are very effective. The newer medications generally have several advantages over the older, and they've got fewer side effects such as the trembling and the stiffness of muscles and the dyskinesias. They have less risk of developing tardive, which can be quite irreversible, and they can also have a better outcome in mood. They may need more severe monitoring though to ensure that the side effect profile is monitored. So really, I suppose my stress to you in relation to medications is to ensure that you understand what you're administering. If you don't understand what you're administering, you're just giving a depot and you're just checking it, I would be asking the GP to give it.
Renee, it's Jo here. Can I just jump in
Sure.
and say really that applies to all medication, but it's really great to hear about the specifics as well. So, yeah.
Absolutely. Thanks, Jo.
Thanks.
So these are some examples these are three snippets of some mental health treatment plans that we've recently received in our intake service. So over on the left, I'm hoping you can see the screen bigger, but over on the left, you'll see that that is the major component of the mental health treatment plan. And one of the biggest issues with the practice software is that they often will give you 2 or 3 options on what a mental health treatment plan could be used. The one on the left obviously is like a summary type tool, but often what happens is GPs will just put 2 or 3 words, which is insufficient if you're having to answer in a coroner's court or for insurance purposes or for whatever. So if you have a look at the one on the left, they're saying that this person has a long-term story of anxiety, depression. They've got no past history, but there's a long-term story of anxiety, depression. There's no regular medications. There's no allergies known. In relation to relevant information and results of mental state examination, all that is said is 3 siblings have similar problems. So then when you look at risks and comorbidities, it says good family support. And then the diagnosis is anxiety and depression. So if this person had gone for an insurance application and there had been a request from the GP, has this person ever had a mental health treatment plan, etc., or a diagnosis, there's a diagnosis based on very limited information. And if I was that person, I would be quite cross. If you look at the person in the middle, it's just a summary letter. There's no mental state. There's no risk assessment. There's very limited information, and that was billed as a mental health treatment plan. So if this GP was audited, they would be in trouble with Medicare in relation to the dearth of the minimal information that's in there. Again, in a court of law or in a coroner's court, if this was pulled up, the GP would be left answering. And then over to the right, you will see there is a mental state exam, there is a risk assessment, there's limited information in there, yet again, this person is diagnosed with anxiety. So one of the things I do want to stress is one of the new reviews, I think from about 2 years ago, Medicare decided that GPs don't have to do a diagnosis to complete a mental health treatment plan. The dilemma with a lot of the tools is the tools prompt GPs to do that. A GP can put down a formulation instead of a diagnosis, and we will go through that later. So, if you think about closing your file, that's what's been sent off, that's what's sitting there against this person. Person goes away and something horrible happens to this patient. This is what gets subpoenaed under a coroner's inquest. So you can see why it's so important that people come back to get their mental health treatment plan completed and not be squeezed into a 5-minute consultation. So let's talk about what does a mental health assessment include. So when we're talking about a mental health treatment plan, all of these components pretty well need to be included. So the components with the 3 dots or the 3 asterisks next to them are the ones that we would be collecting on the day. A lot of the other information should be, if it's well done, embedded into the software package for my client file. So, for instance, I would be finding out what the presenting problem is, have there been any precipitating events, the past psychiatric history, past medical history, current medications, personal history, and family psych history are pretty well locked into the software if this person is a client of a patient of the practice. The other thing we do need to update is drug and alcohol use, because as we all know, if you guys did an audit of your practice information, you would find that most people will write the drug and alcohol usage of their patients in progress notes versus in that little icon with a cigarette at the top of best practice and medical director. I don't know what's in Genie and ZMed. It's been a long time since I've looked at them. But in that icon is where we should be putting the drug and alcohol information and usage and updating it regularly. And that's something that practice nurses can do regularly. That's a template or an icon that you have access to that you can go in and update, so that we can at least make sure that this information that gets sucked out of the computer automatically through a software package is up to date. The 2 predominant things that is really, really needed from a mental health assessment from a GP practice is a current mental state exam and a risk assessment. So if I flick back to these, you can see that none of these 3 really have done a thorough job of a mental state and a risk assessment. And we're talking about doing a clinical handover to a psychologist, a social worker, an OT or a PHN-funded service, or a mental health nurse. That's why it's so important. One of the other things that I think practice nurses and primary care nurses can describe, especially in their formulation, and we'll talk about formulation creation shortly. Pre-morbid personality is a really interesting question for a patient. Basically, what we're trying to understand is what is the normal you. Currently, you're saying you're distressed, you're feeling helpless, hopeless, you're feeling sad, you're not sleeping, all of that. That's how you're feeling now. Help me understand, if I was talking to your husband or your friend or your child or your partner, if they were describing the normal you when you're not feeling like that, what does that look like? Because that allows you to gauge a baseline of where you're trying to get this person to. It's a really good descriptor and helps you always check in on that. So when we talk about mental state exam, again, that's what I was talking about. Mental state and risk assessment are probably the 2 most significant things that need to be done from a medico-legal requirement, but also from a good clinical handover requirement, and also to be able to touch base and see how this person's travelling. Mental state examination and risk assessment are your 2 predominant things that need to be completed fully. As mental health nurses, and I think we've got a mental health nurse in the audience, welcome. Mental health nurses, we've often I learned, pretty old school, I learned by mnemonics that help me remember the main things that I need to keep asking people. So we won't go into the absolute details of the mental state and risk assessment, of the mental state exam, but so I'm just getting my notes up to speed with you guys. Just give me 2 seconds. But Pam's Got Ginny is a great mnemonic, and I think mnemonics are really handy to remind us of some of the things we need to ask people. So this is relative for GPs when they're doing a mental state examination, but it's also good for you to understand what's involved. So when we're talking about perception, we're talking about, are there any auditory, visual, gustatory, we're talking about hallucinations. When we're talking about affect and mood is affect is how the person's presenting, and mood is how they're describing their emotions. So how they're presenting their emotional state versus how they're describing their emotional state. So what is that looking like? Are they euthymic? Are they depressed? Are they angry, elated, irritable, brittle? Or are they quite blunted and very slow? Not a lot of expression and very slow conversation, very quietly spoken. So how is their affect, which is how they're presenting their emotions, and what is their mood, is how they're describing their emotions. Memory, so, memory is a typical time, place, person. Do they remember where they are, what date it is, those basic sorts of things. Are they complaining about short-term memory loss? That happens a lot with depression and anxiety. They're often forgetful, and attention, their concentration is quite poor. Is their speech, how's their volume and their rate of their speech? Is it fast? Is it slow? Is it quiet? Is it loud? What's happening with their speech? Their general appearance is what you're perceiving. So while someone might say that they're feeling quite depressed, they might be well-dressed and well-kept. So it's a little bit incongruent. It's not saying it's wrong, but it's a little bit incongruent, or vice versa. Sometimes people's grooming is not so well kept, and they're looking quite shabby, and how they've normally presented isn't how they're presenting now. They're things, especially if you know your practice population, they're things that you will pick up with Mary when she comes in for a chronic disease. It might be for an ulcer check, and you're doing a wound dressing, and Mary's come in, she's normally well done, dressed and lippy on and quite excited, and today she's quite dishevelled, no makeup, and quite disfragmented. And you know something's going on with Mary. You know what's going on. So that's a really good indicator to say, okay, maybe we need to get Mary to see the GP. And then we talk about thought, that's in relation to content, stream and form, but also it might be around disorders of thought, so delusions, and are they a bit paranoid and so forth. Then we talk about judgment. So judgment's around someone's ability to make a decision based on what's happening, a rational decision about what's happening, and being able to make plans of action. People who are quite impulsive have poor judgment. So judgment's always a really important thing to understand. Intelligence, we're not doing IQ tests here, but we really are, whether people are able to understand the things and the concepts that we're talking to them about, or even to be able to describe what's going on for them. And then we're talking about motor activity and behaviour, so that agitation and restlessness, or that really slow, what we call psychomotor retardation. And it sounds quite a stigmatizing statement, but it's actually your thinking and your body movements are so slow that it's almost like a slow motion. And then there's insight. Does the person understand what's going on for them? Does the person understand that they need help? Is the person accepting of it? So then again, as I said, the other major part of a mental health treatment plan is assessing for risk. Anyone can assess for risk, but in truth, a risk assessment should be done by someone who's trained. There's nothing wrong with a primary care nurse or a practice nurse asking about or understanding how to assess for risk, but it does need to be consolidated and supported by a GP. So one of the things, and this often happens with our elderly as well, when we're assessing for risk, we're not just assessing for suicide, we're actually assessing for a whole variety of factors. When we talk about self-harm, we're talking about accidental or purposeful. So some people who are quite distracted and quite depressed may have a lot of accidents, might bump into things, might drop things, might accidentally cut their hand because they're not thinking and they're not focusing. Or it could be purposeful. If people are paranoid, or if people are feeling quite threatened or impulsive, there might be harm to others as well. And often there is a past history. there's a risk of adherence to treatment. People who are getting severe side effects, and this is why it's really important that we understand the side effect profile and we ask about it. If they're suffering severe side effects, no matter what medication it is, they're less, they're more reluctant to stay on it, and they won't adhere to the treatment. Resilience and vulnerabilities, especially around COVID. We've got people, especially in Victoria, locked in their houses. Now we're on nearly walking into week 8. We've got a lot of domestic violence is on the increase, and there's a huge increase in alcohol intake. So the vulnerabilities are significantly high. Also, just with that, we've also got a lot of people living on their own, so it's starting to cave in. And then we talk about protective factors. So protective factors are the ability to make decisions, stability of a supportive environment. Are they risking losing their home, their job? Have they got a carer that can support them? Religious and cultural beliefs can create or make protective factors difficult, because some religions don't believe in mental ill health, etc. And then we're talking about suicide, and that predominantly sits around suicidal ideation, suicidal intent, and a suicide plan, which we will talk about. So in relation to suicide, there are significant components that create larger risk factors. There's age, sex, and social status. So at the moment, we're seeing significant rise of, it's even higher, it's getting higher, especially in rural areas at the moment, from 17 to around 35-year-old males in rural contexts. Past and current mental illness certainly increases risk factors. Previous history of attempts, and especially lethal attempts, increases risk factors. That presentation, I don't know if you've ever felt it, those feelings when people are sitting there talking with you, you can feel your shoulders sink as they describe their levels of hopelessness, helplessness, and worthlessness. It's infectious. You can feel yourself sink into that. Current ideation. So there's lots of people who have suicidal ideation, but never, ever would ever think about attempting suicide. They've just had thoughts of it. But they've got way too many protective factors that help bolster them and stop them from moving through. But there are, so suicidal ideation with a plan and with history certainly increases, and with intent certainly makes someone very high risk. Life-changing events. A family member who's had a history of suicide. It's really interesting that it really almost like doubles the risk of suicide for offspring and other family members, especially around anniversaries. Life-changing events, so unemployment, retirement, lockdowns, coming out, going back in, those sorts of things can continue to increase risk factors. Physical illness, and that's why, I will be talking a little bit about chronic disease and mental health. Very rarely, as I said, can you have a chronic complex mental illness, chronic complex physical illness or a terminal illness without there being some form of psychological distress sitting in the background. And often people who have severe complex mental illness have a lot of comorbidities that are sitting there. The two fairly well go hand in hand. We've talked about that, and we've talked about the isolation factor in relation to COVID. Some of the things I did want to talk to you about, which could mar or blur any kind of understanding of what's going on for someone, whether it be for a mental health condition or a chronic disease condition, and that is substance use. So we're talking about drugs and alcohol. It could be marijuana, it could be lots of other kinds of drugs, But definitely alcohol is probably our biggest issue that goes fairly well unhidden, because people just don't own up to how much they drink. That's why it's really important to ask those questions. I often will say to people, so tell me about your drinking. How much would you drink in a day? 3, 4 glasses? I always go a little bit more, because then people are more likely to say, no, it's only 2 or 3. And is it every day? Every day? Oh, yeah, no, yeah, most days. So people are more likely, if I go a little bit more in the question, they'll tend to feel more comfortable in opening up. Substance misuse, as I say, occurs frequently with mental illness, and they interact negatively with one another, just like substance misuse with chronic diseases interact negatively on one another. Physical illness, as I said, people with chronic illnesses will have psychological distress or depression, and vice versa. And assessment and treatment, I would highly recommend that when you're doing a chronic disease management plan, always do a K10, which we'll talk about shortly. Provide that to the patient and ensure that they do it, because it allows you to just monitor how their psychological distress is going. The good thing with a K10 is that it's a subjective score, so the patient actually does it on themselves. You're just providing them with a tool and giving the GP the outcome. You're not administering it, and you're not making a diagnosis because of it. So let's take a moment to think about what happens to you when you become distressed emotionally. What happens when you first start to feel stressed? What happens when your stress starts to escalate? And what happens when you hold it in and pretend it's not there and just keep soldiering on? What goes on for you? So distress can often feel like this, and I think this is a great little tool to help people describe what often is happening with them, because sometimes people just can't put words to their physical or emotional state. So this is in your packs. This is a tool that you can use, and it's really great to help people describe it. So if someone says, I really can't explain what's going on for me, when they might be sitting there and you're doing their wound dressing, you can say, look, I've got a little picture, and this might help you describe what people unpack what's going on a little bit for you. And also then allows you to describe in your formulation or a summary in your progress notes of what you're seeing with this patient, that allows the GP to understand a little bit more. Sorry, I'm just tracking some of the questions that are coming through in the chat as well. So identifying psychological distress. What often happens when we have distress is that we see in our patients is that there's an increase in forgetfulness, accidents, confusion, and often people are doubting their capacity and their capability. People who, and this could be with our staff as well, and our colleagues and with ourselves, when we're feeling a bit stressed, we start to lack, our confidence isn't there as much, and we start to question it, and what we call ruminating. Ruminating is a great word, because it's what it actually means. It's about it like a cow. They chew their grass, they chew it, they bring it back up, they chew it, they bring it back up. And that's what we're doing with our thinking. We're ruminating, we're chewing over it, we're swallowing it, we're chewing over it and swallowing it, and it seems to just sit there, and sometimes it can grow, and we start to doubt things. We feel that we have the reduced ability to perform our normal tasks. People can have mood swings, tearfulness, anxiety, expressions of worrying thoughts. We have increase or decrease in energy levels. We might be restless, or we might be just really lethargic and couldn't be bothered. There's often an increase in withdrawal, not going to social events. Of course, we can't do a lot of that at the moment, but not typically doing what we would normally do, trying to not go to work and not engage with family and friends. And often there's an agitation or an irritability, and I like to call it a brittleness. We tend to be a little bit more brittle. Sometimes it's with our family and our animals and so forth. We're a little bit more snappy, or it could be around our work colleagues, and we might start noticing that, but we'll also start noticing it in our patients, especially at the moment when they're coming in. They come into a practice. Some of you are seeing patients still in cars. Some of you are allowing the 1.5 metre distance with the chairs moved in waiting rooms. Each GP practice is doing it very differently, but you'll notice that there might be more brittleness and less patience for people when they're coming in, because it's confusing, it's a little bit anxiety provoking for them, and they're unsure.
Renee, I suspect that some of the nurses out there will find that familiar at the moment. So.
And I can imagine that even the receptionist is seeing it as well, that if you are huddling regular as a practice, I can imagine the reception staff are seeing, people jittery or a little bit more conscious. And if someone coughs in a waiting room, someone's getting quite anxious. There's all of this stuff that happens. And we've got to remember, we've even got that's not personable anymore. We've got Perspex screens, we've got hand sanitizer everywhere, we've got masks on. We've really lost that ability, that personal touch. I don't know if many of you were around when computers first started in general practice, and patients were always complaining that GPs' faces were sitting in front of computer screens whilst they were all trying to quickly adapt to this new environment. And now, people are saying, oh, I can't see anyone. There's masks everywhere. I'm missing verbal cues here. So it's very interesting times. In severe cases, our patients or even our staff and our family may have increased distress and deterioration of normal problem-solving ability. People can just come and say, I don't know what to do. I just don't know what to do. And we can offer things, but they can't even make the decision of the options that we give them. There might be extreme reactivity. You might get people that are less patient, more reactive around you. And, some people move to agitation and verbal abuse and possibly threats of assault. There increased paranoia and hypersensitivity, and there can be a loss of touch with reality, especially with our more chronic clients who have had quite significant psychiatric mental illness in the past. And one of the things that I do know that has been reported is there's been an increase in medication, prescribed medications, because our drug and alcohol clients aren't able to get the typical drugs that they would normally be able to purchase because they're pretty well drying up at the moment. So that's adding an additional burden, especially to our pharmacotherapy GPs and clinics, where we might be seeing more of that drug-seeking behaviour in our patients. So let's talk about a crisis. And I'm just realising we're running very short of time. Let's talk about a crisis. So a crisis occurs when a trigger event or an accumulation of events, it prevents someone from being able to function in the way that they had previously. Somebody could have that same event 2 days ago and be okay, but today it can cause quite a crisis. A crisis involves circumstantial situations that cannot be resolved by a person's usual problem-solving resources at that time. A crisis is a perception or experiencing of an event or situation as intolerable at that moment and difficult, and it exceeds that person's current resources and coping mechanisms. The key things to remember about a crisis is that crisis is seen as a non-illness response. It's just when somebody's feeling they've lost control. Often what happens is that we just need to step in for a short time to allow them to try and settle and get breath again. And it might take an hour or two for them to then be able to take control again. And then we provide them with the wraparound support so it doesn't escalate again. So a crisis can look very much like this. We have this steady state, something happens, a crisis stimulus happens, tension mounts, and that stage 1 mounting tension is so important for us to remember for ourselves, but also for our patients, because it's at that moment that we decide to ignore that tension and just keep rocking on and moving on until we lose it. We might get really snappy, we might cry, we might have a hissy fit, or we might actually have an event. So there's always early warning signs that often happen that we tend to ignore until it becomes quite loud. And what we're trying to do in crisis management, because obviously the crisis has gotten to a significant escalation, is we're trying to mobilise some resources for people so that they can eventually get to holding on and working through what's going on for them with some support. Something to be mindful of is that you may not be the right person on that day to support someone through a crisis. If you're having a bad day, or if you've just gone through a really difficult time, then your own experiences, your own emotional state may greatly impact on how you respond in a situation. And that is okay. That is where it's really important to tag team with your colleagues to ask for support and assistance, and maybe just be in the backdrop rather than be the person at the front. So a very quick mnemonic, again, or this tool is in your packs, is DEACT. So DEACT is a good way of you understanding and remembering how to start working someone through a crisis. So if you think about D is around defining the problem. So often people, if you think about a typical crisis that might happen at a reception desk and someone's gotten quite angry, you'll run in and you're not really sure what's going on, but you go, okay, I've got to try and figure out what's going on here so we know what's happening. So trying to define the problem. And it might be that someone wants an appointment with a doctor and there's no appointments available, and they're just quite distressed and having they're in crisis. So defining the problem for that person and trying to understand and making sure you can reframe that back and saying, you know, I hear what you're saying is this, isn't it? Have I got you correctly? Yes, you've got me correctly. Okay, all right. So how about you and I go and sit down and let's try and work out what's going on here. And taking the person away from the waiting room or from the reception desk is probably the best thing to do, but always make sure there's someone else that's coming out with you so that you're not alone with the patient. One thing to be mindful of and action is action your response, and keep an eye on, do a quick body scan and see what you're doing. Notice your body response. Are your arms crossed? Are your arms on your hips? Try and make sure that you're maintaining a very calm posture. And I always say, just stand there with your hands on your. I can't stand up and show you, but on your thighs outwards at them, not on your hips. So almost like you're in a standing meditation pose with your hands out, because it actually shows that you're not being aggressive. Talk quietly and be repetitive, because sometimes people need to hear what you're saying a few times before it's sinking in, because they're quite distressed. The idea now is to de-escalate and take some control. And again, you could have a whole session on crisis intervention, but the main thing is what you're wanting to do is say, how about, are you happy for me to try and organise something for you? You sit down and have a cuppa, and I'll try and organise something for you while you're trying to take some breath. Are you happy for me to do that? Most people will often allow you to do that. And I will explain to you every step of the way what I'm organising, so we're doing this together. I might not be able to get you an appointment, but I'll try and organise something just as good, whatever it might be. And then make sure that you set this person up for some treatment, and you're collaborating with them about what that will be. Well, okay, we're going to book you in for the GP tomorrow. Between now and tomorrow, this is what we've sorted out. You can ring this line. You can, here's some sleep tips. I've organised a heat pack for your pain, whatever it might be, and the GP can see you tomorrow. Are you happy with that? What else are we missing here for you? So allow them to be part of that. Again, thinking about your the volume switch, I love using the volume switch, and I'll often say to people, not in the height of it, when you've got them sort of settled, is to say, when you were really quite distressed before, if you imagine a volume switch, where do you think you were on that volume switch when when I first saw you in the waiting room? What was going on for you? Where do you think you were? 10 out of 10, a 9 out of 10, an 8 out of 10, where do you think you were? It allows people to reflect where they are, and then you can say, okay, where do you think you are now? And they might say, oh, about 7. Okay, that's good. We've come down a few bars. Let's try and get you down to about a 6 before we go home. If that's the kind of thing that we're wanting people to do, what is it that we could do to help you to get to that? And people are often, by this stage, able to talk about this sort of stuff. What's worked in the past? What's helped you? How can I help you with that? So, in relation to documentation, notation and tools, as I said before, it's really important that as nurses, what we can do, as practice nurses, what we can do is we can make comprehensive notations in the progress notes to allow the GP to be further informed about what you're seeing, because sometimes the patient won't always be as honest in front of a GP. It's really important to bring a formulation is when you as a nurse bring the story together about how Mary has presented today, why she, what she has said has precipitated this difference in the way she's presenting, how she's describing what's going on for her. Remembering you're talking about symptoms of life. What are her symptoms? What is she describing and how is she feeling? You can use verbatim statements. Mary says, I feel terrible, I feel hopeless. So please make sure, rather than saying Mary is depressed, Mary is anxious, you can say Mary's describing feeling depressed, Mary's describing feeling very anxious. She says that she has got palpitations, racing thoughts, describe what that anxious feeling is. And you can put that into a bit of a summary. And in this, you can also say, I invited Mary to use the K10 whilst I was dressing her wound, so that we can then get the doctor to review that. So here's an example of a formulation. A 49-year-old married mother of 3 grown children attended for her annual diabetes cycle of care. During assessment, she presented quite labile, tearful and sad. On inquiry, the patient stated that she had recently lost her job and was extremely worried that she would not be able to afford her medications and not be able to provide adequate support for her family. She describes that she is having problems sleeping, has increased worried thoughts and irritability, and has admitted to starting to increase her alcohol consumption over the past few weeks to help her get to sleep. The patient has a family history of mental health issues, depression, but no personal past history. So as you can see, we've not said that Mary is depressed. We've not said that Mary is anxious. We've not said that Mary is abusing alcohol. We've described what Mary has said. And it's quite a thorough formulation. It's quite good and allows the GP to get a good handle of what's going on for Mary. So just to recap for practice nurses, in relation to mental health, we can't do a mental health treatment plan. What you can do is you can do a K10, which I'm going to show you in a moment, and a formulation, and you can write that down so that the GP has got all the information there to make their mental health treatment plan implementation quite easy. We often get asked about, can a patient have both a GPMP and a mental health treatment plan? A GPMP and a TCA can be done as well as a mental health treatment plan, but they can't be both done for mental health. A GPMP, if I've got depression and I've got diabetes, you can do a GPMP for my diabetes and you can do a TCA for my diabetes and you can do a mental health treatment plan for my anxiety, or my depression, I said rather. And you can name me as a allied mental health professional in the TCA because my depression certainly has an impact on my diabetes. So I can be one of the other allied health professionals as a mental health nurse, as a psychologist, social worker, whatever it might be. I can be named in the TCA, but you can't have a GP management plan that relates to mental health. Does that make sense? I know you all can't say yes, but I'm hoping that makes sense. So otherwise it's seen as double dipping.
I'll say yes.
The other thing I will say is that sometimes, and I know we have a mental health nurse in the audience, but sometimes mental health nurses will ask for a GPMP and TCA to be done because mental health nurses can't fill the Medicare item numbers, unfortunately. We're fighting that fight, but we can't. So if a GP wants me as a mental health nurse to see you, the only way I can do that is through the 5 allied health item numbers under a GPMP and TCA, under the enhanced primary care items. Unfortunately, that really, I don't think, is a fair way for patients. I think patients need to be able to have the full option of mental health treatment plans. So tools nurses can use, and I know we're running out of time. I talked about K10. So a K10, these are in your practice software packages. You can print them out, and as I said, they're a subjective tool, not an objective tool. So that means that it's not you assessing the patient, it's the patient assessing themselves. So whilst you're waiting for the person to see the GP, or whilst you're doing their wound dressing and you see that Mary's looking a bit wobbly, you can ask her to fill this out. Or you can help her fill it out, but it shouldn't be your interpretation. It should be what Mary's stating is going on for her. It can then be loaded into the software package, and the GP can have that as part of their tool. It's a really handy tool to use, and it's something that I would highly recommend you use for all your chronic disease patients, because I would imagine most of them have got some levels of psychological distress. Other tools that you have at your disposal is the alcohol screening tool. We've got various things like sleep hygiene. We've got health coaching tools that are sitting in the software packages. And the other one that I wanted to quickly show you is the mood anxiety chart. If it's going to be 2 or 3 or 4 days before someone can see a GP and they're not in a crisis, they're just a bit wobbly, and not everyone can see a GP that day, certainly help the patient to make an appointment to see the GP, and maybe offer them to do this mood anxiety chart. What it is you have happiness, sadness rating at the top, and you have anxiety and tension at the bottom. So what you do is you ask people to fill this out 4 times a day. I often say to people, fill it out when you're having breakfast, lunch, dinner, and bed. They're usually the 4 times people remember, and you get them to grade it. It's pretty self-explanatory, but you know, happiness, sadness, 10 out of 10 is the happiest, 0 out of 10 is the saddest you've ever felt. Where are you at 8 a.m., 12 p.m., 6 p.m., 10 a.m.? And likewise with your anxiety tension rating. 10 out of 10 is pure panic, 0 out of 10 is your fast asleep. So it's really good for people to fill that out. They can write different things down the bottom. There are prompters, things like, has someone had their period through that time? Have they been drinking? How much did they drink? How was their sleep for that night? And therefore, the GP can get 2 or 3 pages of this before they see someone, and they can get a really good picture of what's going on for that person. Oh, that's just an example of one filled out. So, remember that patients rarely book the appropriate amount of time. Assist the GP by ensuring all the necessary information is in the software so it can be pulled and extracted from the mental health treatment plan. When you're doing anything like a GPMP or TCA, please don't leave any gaps. You can help with the K10 and get it filled out and completed and put into the software package. You can support the patient by scheduling the follow-up appointments, because often what happens is people will go to the reception desk and they can't make an appointment for 3 or 4 weeks, yet you know this person needs to be seen in a couple of days. So be that advocate for that person. Give the patient some homework, a mood chart, a journal, a smartphone app to help them, to support them. And as a GP, I would always say, if you haven't got enough time, deal with the main issue, get them back in. And you can build an appointment over scheduled appointments, or get them back in for a longer consult, and make sure you've got a recall in your system to make sure that person comes back. So I just quickly want to touch on some referral pathways, and then I'll close. To go along with the STEP mental health model, you'll know that there are different referral pathways. Currently under Medicare, MBS, Better Access, the clinicians that are allowed to use those services are clinical psychologists, general psychologists, mental health social workers, and mental health OTs. With the implementation of a mental health treatment plan and the billing of an item number, that opens up or triggers 6+4 MBS subsidised sessions. I'm going to stress here that they are purely subsidised. They are not necessarily bulk billed. And it's really important to understand that a clinical psychologist rebate is around 123 and a general psychologist around 83. Very big difference if they're all charging $200 or $180. So it's really important to understand what that gap fee is, because that's where a lot of people fall off from going to continue on through the MBS cycle, because the gap fee was something that they weren't expecting. So you could be an advocate for a patient or find out what that would look like, or give people options on cheaper options through Medicare. In relation to COVID, as we said, there are currently available COVID item numbers. They're telehealth, but they're not necessarily bulk billed. So please be mindful, whilst they're there, we also have to find out whether they're subsidised or not. I mean, whether they're free or not, because there's a lot of our patients who are on JobKeeper, JobSeeker, and can't afford that gap fee. Then you've got the brother program of MBS Better Access, which is the Mental Health Step Care program. A lot of PHNs still require a mental health treatment plan. Some people don't. So really, what I suggest you do is type in PHN locator in your local area. You probably know who your local PHN is, and have a look what their programs are so you understand what the referral criteria are. You could also use the Referral Pathways tool, which will also outline how to refer to the PHN programs. These programs are free, and therefore specific cohorts that have got low income or they might be child mental health, youth, called Aboriginal and Torres Strait Islander cohorts that are more have more predominance of mental ill health. And the last ones, and I won't go into this too much, but I just want to highly, highly stress this. As practice nurses and as GPs, we don't use the online internet and phone apps enough to be an adjunct to our care. There are plenty of mood charts that can be done online, on a smartphone app, diabetes smartphone apps, chronic disease smartphone apps. There's a variety of different things that we can use to support patient management, and I highly recommend that you become familiar with them. These are my favourites, and these are the ones we use and recommend all the time. And if you're working with children, Smiling Mind, and young people, and even adults, in truth, but Smiling Mind is just sensational. Over on the right, when you've got this attachment sent to you, that is the eMental Health directory that also describes to you all the different smartphone, internet, and phone services available. And also the Head to Health website has zillions of these sitting there. They're all evidence-based, and they're very, very good. I can't recommend them enough. The other thing that's really new, pardon me, in Victoria is the Head to Help hubs. These have just been launched on Monday, and I highly recommend you look if you're in Victoria to find out where your local hub is and how to access it. But basically, there's a state 1-800 number that you can call, that people can call to get support and get counselling. There are some criteria around these, but I would suggest you have a look at what's going on in your local area. There's always something different about what's happening. So I just want to jump a little bit to your self-care. Please remember that it's so important to monitor what's going on for you. Practice nurses, practice managers, GPs are all struggling. There's been all these different changes. We're going in to a lockdown environment out. We're in PPE. We've got Perspex, screens up, all this sort of stuff. And we're moving around, and then we're fearful of what we can transmit and take to home. So please just be mindful about how this may impact on you as nurses. One of the things I want to stress that there is that NM support, nurse and midwifery support service, which is free counselling and anonymous counselling, and I highly recommend you use that. I want to also stress that that a lot of practices or PHNs provide EAP services. So Employee Assistance Program is, again, sometimes it's 3 to 6 sessions that are free and are subsidised either by your employer, or some PHNs are doing it for nurses. So that's really exciting as well. And I can't stress enough, it's okay to not be okay. And I know we're all probably sick of that statement, but it's a very true statement, and it's really important to reach out. Jo, did you want me to finish off now, or I'm just mindful of the time?
I think we've just got a couple of quick slides left to go, Renee.
Yep.
So if you wanted to whiz through them just
great.
quickly, and then we've just got one question to ask, and just won't take too long.
Okay. So just some self-care for you guys to think about. So when you're at home, when we say keeping fit, I'm not expecting, and we're not suggesting that you should be a marathon runner. Just going for walks, getting out, getting some sun, getting some fresh air, even if it is through a mask, is really important. If you're in Victoria, currently we can't access gyms. I think in other states you can, so it's very different across Australia. But, if you can get to somewhere where you can get some exercise, it's really important. Eating healthy as much as possible, reducing your sugar and your junk food intake is also really important, because it really doesn't help you. It creates that lethargy feeling that sits around you, and it's hard enough when you're feeling pretty flat in the first place. Do positive activities, warm baths, face masks, that sort of stuff. Go and get pampered if you're allowed to. If you're lucky enough to go and get your hair done. Currently, my roots, I'm looking like Shakira, and my roots are like 4 inches long. So, go and get some pampering. Learn some yoga or meditation or mindfulness. As I said, Smiling Mind is a magnificent app, and there's lots of also free and online yoga and meditation courses that are happening at the moment. Adopt some good sleeping habits, and I'll talk very quickly about sleep in a moment. And stay connected. Where possible, stay connected with your network. With work, limit working extra hours, and if you are working from home, make sure you can shut down your work office so that it doesn't intrude on your personal space, or shut your computer and take it away from your personal space so you can actually shut down where possible. Try and schedule as many meetings during work hours. I know we're doing this in the evening right now. Take regular breaks and annual leave if you can, but if you can't, take some regular breaks. One of the things I noticed is that we seem to be more on screen. I know that our team is, and we're noticing that our backs are getting sore, our necks are getting sore. So, we actually have in our calendars a reminder to get up and do just a loop of the house, and you could do the same in the practice. Do a loop of the practice and go back, just to allow yourself to just move. Set realistic deadlines, make use of the EAP, like I said, or the nursing midwifery support line, and use technology positively to reduce their stress, rather than using things like Facebook and social media to increase our stress around what's going on. A special mention about sleep, especially for those of you who have got little children, and we're trying to juggle the COVID environment, the school environment from home, all that sort of stuff. When we're trying to get our kids to go to sleep, we are no different in how we have to wind down as well. So we have to think about how much coffee, nicotine, caffeine, alcohol we are having as an intake in the evening before we go to bed, because it will definitely impact on our ability to get to sleep. And alcohol wakes us at 3, 4 o'clock in the morning if we've had a lot of it. And if you're menopausal, alcohol will also increase the inflammatory response and get the hot flushes totally doubled. Stick to regular sleep patterns. Try to avoid catnaps, because they will interfere with your quality of sleep. Exercise, as I say, it's really important. It's great, especially in the morning if you can, because it increases your endorphins. Ensure that you have comfortable sleeping environment, and the temperature in your room is normal, not too cold, not too warm, so your body isn't responding. No phones, TVs, or work or laptops in the bedroom. It's really important to shut down or turn your phone into night mode, so you're not getting the beeps and the buzzes through your social media devices. Try to relax and slow down 30 minutes before you go to bed. Think about what you're watching and listening to before you go to sleep. Your mind needs to slow down as much as your body does. Your body might be physically exhausted, but your mind might be really stimulated. So maybe doing something like a meditation app or listening to really soft music to help you wind your mind down. Baths are fantastic as well. The other website I really wanted to stress to you guys as organisations and businesses and practice nurses, Heads Up is fantastic to help you think about what sort of workplace resources and mental health well-being resources you need to have for your organisation, for your practice. And they specifically talk about GPs and practice staff as well. So I highly recommend that you're going onto the Heads Up website of Beyond Blue, and you can register and get your emails, which always have some really great information in it. We send it around to all our staff, and become part of their mental health workforce alliance. It's actually it's really, really good. So we've talked about that. Just ensuring all your patient information and history is up to date in the software. Ensure the K10 is available in the software and upload it once it's completed for the GP. Facilitate all patient appointments and follow-ups. This is stuff we can do to support our patients so they don't disappear into the ether. Set up reminders and recalls for the GP to prompt them to review the patient. If you're seeing the patient, you know the GP's seeing them tomorrow, put a reminder in there to say, please make sure you start a mental health treatment plan. Mary was very wobbly today. Whatever it is you need to do, but put it in as a reminder. Upskill by doing various courses. So there are lots of courses, and I highly recommend mental health first aid and advanced suicide intervention skills training. However, at the moment, they're delivering that training in very different hybrid approaches, so you might have to look at where you can get those. There's a mixture between online and face-to-face. But also Black Dog run a lot of training, and also APNA have some mental health training modules as well. And that's it for me. I'm sorry, I know we've gone a little bit over time and we had a bit of a glitch. So that's it for me, everybody. And I think we did have a question. Is there an equivalent for Head to Help in New South Wales? No, there isn't an equivalent at this point in time. We think that there might be a lot of these being launched across Australia over the next 3 years. However, they pushed forward the Victorian launch because of our significant lockdown issues. But there are no more going out to New South Wales and any other state at this point in time. Joe, we've just lost Joe right at the crux of the matter. I can take over. Just give me one moment. So we've got a final poll. If I can ask you, please, if we can maybe bring up the poll, Jared. And we've got a final poll, which is number 5. What actions are you likely to take within your organisation or place of work to support patients with mental health challenges? If I can ask everybody to please do the poll is up. I'll give you a couple of seconds to do that. Fantastic. Okay. So if anyone wants any more information or if there's anything that we've missed tonight, if I can ask you to just please pop it in the chat, because we can save that chat and we will follow up and certainly get information back to you as quickly as we can. The last time we ran one of these, we had 3 or 4 questions that I couldn't answer at the time because they were in relation to involuntary treatment of patients and so forth, and it's very particular to state, so we were able to just answer that via email. So please feel free to pop any last minute questions in the chat. I would like to thank Joe and APNA for inviting me to be the facilitator for tonight, and thank you all. And we apologise for some of the glitches that's happening, and we just hope that you are all travelling okay. And if there's anything further that you need support with or other training needs, please let APNA know. There will be an evaluation sent around to you if it hasn't been already. And just reminding you that this has been recorded, and a link will be sent with all the attachments and the links later in a few days. Again, take care. Please take care of yourselves. Please look after yourselves, and we thank you. Good night.
Thank you, everyone. Good night.